Okay, well, 5 minutes, reminds me of the person who once said to Winston Churchill, why don't we take 5 minutes and you can tell me everything you know? To which he replied, let's take 5.5 and tell everything we both know. Now, I agree with Gail that it's extremely important to deal with the context. So I'm going to make 3 broad points. First of all, a macro perspective that on what is shaping health policy and health services around the world. I'm dealing mainly with the United States, but as you can tell, I don't speak Americanese, so I'm very familiar with the British system and with the New Zealand system. I want to very briefly mention something about the erosion of primary care in many developed countries, and I want to suggest, if there is more than a minute left, to talk about future directions. Now, context. Now, this is like that game that we used to play, Can You Spot the Monkey? Can you spot the interest groups? And these are all in the US health system, the interest groups that are competing on the stage. Maybe you can't see it from the back. But on the one hand, you have people lining up to get in. They pay for the system, having trouble getting in. You've got also investors pushing forward. You've got doctors helping it forward. You've got the nurse putting bandage on the smokestack. 250 in the United States, 250 to 500 billion going up in smoke on wasted services. And you've got objectified patients coming out there. This is an archaic, antiquated and outmoded system. You've got objectified patients coming out at the left there, and you've got health services and policy people with a clipboard there observing the process. So I think we need to be mindful, if you like, of the political economy of healthcare, and I agree very much with Gail that we need to look at the context, and this is the context of change. Now, turning to the second point, primary care. This is my vision of primary care. You've got doctors playing with sandcastles in the sand, and my colleagues in Harvard and in Boston are very much perplexed by payment reform. People saying train more doctors, change the curriculum. There's a movement towards patient-centered medical care in the medical home. But these two birds at the side are saying, do you think they'll survive? No, and they won't even know what hit them. So most health services researchers, I claim, are overlooking the macro trends that are engulfing tsunami-like primary care in many countries around the world. And this is the context in which we've got to look at change. So if we do those things, payment reform, giving doctors more money, changing what we call primary care, and changing the medical curriculum, I don't think it'll yield a great deal. As the saying goes, if you always do what you've always done, you'll always get what you've always got. And then for the next primary care, how many minutes do I have, if I have any? 2. So there are all kinds of reasons, extrinsic and intrinsic, to why primary care is declining. The state in many countries faced with fiscal crisis is bailing out and trying to offload it to the private sector, private sector with austerity measures. There's been demographic changes and epidemiologic transitions to palliative care. Non-physician providers have come on the scene. Internet, I think we haven't even begun to comprehend what that's going to do to primary care doctoring. Corporatization and alienation of providers. And then doctors and other healthcare specialists have also contributed to the decline, with unintended consequences of guidelines, which creates formulaic medicine and a few other things. So where are we today with primary care? Again, talking about context, and I don't think I'll get onto the futuristic, but that's where we are, I believe, already happening. It's already occurring. In the United States, about 10 million people annually are already using online care. 15 states have passed laws requiring that private insurers cover the services provided online. A Cahspr study showed recently that for care of diabetes and hypertension, online care is actually to be preferred to traditional in-person care. I'm a great supporter of primary care, and for most of my career I've taught and researched primary care at Mass General Hospital in Boston, and I'm very concerned about these trends. But I think this is what's happening. And I notice even in Ontario here, I read the paper yesterday, the Minister, Deb Matthews, advocates virtual visits. This is already occurring. I don't think I've got a chance to go on to the next slide, actually, about the future, because I've run out of time. But I think that's where we're at. So we've got macro changes, interest groups shaping where we go and what we do. Each of those interest groups there's about 8 of them that I could identify, have their own interests, and they're shaping the whole terrain. In addition to that, I think primary care, for a variety of extrinsic and intrinsic reasons, is eroding. I'm not saying that primary care, which I think is vital for population health, by the way, doctoring is going to go away, but not primary care. It will be, I think, delivered in other forms. And we can talk about that during the discussion. I'll be happy to. And finally, I think that we haven't yet comprehended what will result from digital or cyber doctoring. We've seen with banking and travel agents and lawyers and even teaching, where a lot of it's online now without even seeing a professor. Why will that not happen in medical care and in primary care? Thanks very much. Regarding the issue of access to care, many educators in Boston and parents would say, who would want increased access to the Boston school system? It is so deficient. It is so underfunded. The teachers are so demoralised. So why do we want increased access to the system? Translating that to primary care in many countries, there's a hell of a lot wrong with the way in which primary care is delivered and the ability. I could tell you study after study about how poorly routine conditions are diagnosed and managed, even for well-known conditions, easily diagnosed conditions like diabetes and other things. So there's a lot wrong with primary care. For me, as someone interested in policy, it seems to me that it boils down to a few simple principles, but rather complex. First of all, what we've got to do is work out what works. That's the starting point, what works. Roughly, I mean, I liked Michael's point about the surgery. That's about 10%. By just about every estimate, about 50%, at least 50% of primary care is ineffective, or has never been or the effectiveness of it has never been evaluated. So that's the system right now. So much is ineffective and wasteful. So once we work out, how do we work out, so first of all, working out what works. The only way to determine what works, of course, for any people here who are evaluation researchers, is by randomised controlled trials. And so if you're going to have effectiveness-based resource allocation, you've got to allocate resources to those things that have been shown, probably repeatedly, to work. Now, what does work for things in primary care? Well, I'll tell you, nurses and nurse practitioners. We still have, as Michael pointed out, we still have a system dominated by other interest groups. The one thing I always tell my students, and other colleagues who will listen, is we don't need any more studies of the effectiveness of nurses and nurse practitioners. For 50 years, we have shown over and over and over again that 80% of what primary care doctors do can be done as cost effectively by nurses. But that's not the situation we're in. We obviously reduce nurses, I showed in that cartoon, to subordinate roles, and they should be given absolute authority and autonomy to diagnose and to prescribe and to refer for testing, any testing. And that, I think, would improve access greatly. It will be opposed, as it is right now around the world. Interestingly, despite all this evidence on the effectiveness of primary care, of nurse practitioners, it has never made any difference in the context of the United States for 50 years. It has done nothing. Study after study has shown this. But now it's all changed. Why? Because when President Obama introduced healthcare reform, he enfranchised 32 million more people who previously had no health insurance. That put the cat among the pigeons, because there's 63,000, there's a shortage of 63,000 primary care doctors in the United States already. Only 2 to 3% of medical students want to go into primary care, so there's a terrible problem. So now, where do we look for the solution? Do we look to the solution to train more doctors? Well, no, that takes too long and it's too costly, as our British colleague mentioned. So what about changing the name of all this to patient-centred medical home? Well, that doesn't really do anything according to most everyday practitioners. What about changing the medical curriculum? Would that help? Hey, I think there might be a solution, you know. There are all these nurse practitioners out there who can do just about everything that a primary care doctor can do. So what has been forced on the United States system is the imperative of drawing in the talent that's already been there in the form of nurse practitioners.